Alright, let's just slide right on into nursing process. Most of you have, man, this computer's slow on Saturday. Most of you have heard of the nursing process, and you as LPNs should know the nursing process. Without the nursing process, our nursing really can't be done in a methodical way. When I see the word and want to say the word, sometimes it really messes up. And I'm not even seeing the word. I'm seeing it inside my head, and I still want to say it wrong. Okay, so the nursing process is a 5-step process. All right, nursing process. The definition for the nursing process is that it's an organizing framework that we use for our nursing profession. We use it in nursing to help identify our patients' problems and to treat their diagnoses as we take care of them. So the nursing process has been in nursing for a very long time. It's how nurses think and how they identify patient problems, determine outcomes, and prioritize nursing care for their patients. Basically, what nurses do was officially labeled as the nursing process in the 1950s. Lydia Hall was one of the first to refer to nursing as a process in 1955 when she published a journal article. But the term nursing process wasn't widely used until the late 1960s. Referring to the NP as nursing as series of steps occurred in 59 by Johnson and Orlando. Then in 63 there were 3 steps of the nursing process, APE. In 67 we developed 4 steps, APIE. And then in 1974, NANDA came up with ADPI. So those are our 5 steps that have not been changed in over 30 years. Amazing, isn't it? No, is that right? Yep, 30 years. Yep, more than that. 40 years. 40 years and over 40 years. That's almost half a century. So evidently, nursing process works well. So what are the nursing process? We use the acronym ADPI so we don't forget it. So you need to know the nursing steps ADPI. You need to know for your little test purposes that A is for assessment, D is for diagnosis, P is for plan, 4 is implementation, and 5 is evaluation. But that's not all that the answer is for that question on your test. You have to tell me what is assessment, what is diagnosis. So you have to name it and describe it. Don't forget that, or you will lose points. So the nursing process is based on scientific process. It's very useful to use this ADPI for you to be able to remember it. So let's go to step 1. Step 1 is assessment. It's part of the process that's continuous. We are continually assessing. You don't walk in a patient's room, you don't read a chart, you don't look at lab unless you're assessing. And assessing is in the scope of the RN. Assessment is not in the scope of the LPN. It is in the scope of the RN. So be sure that you're reading your Practice Act. Your Arkansas State Act, Nurse Practice Act specifically states assessment is out of the scope of an LPN. So the patient is, of course, assessed initially, and then as we take care of our patient throughout their stay in the hospital or throughout the stay in their home, whatever, we continually assess their care because the patient's condition is going to change, hopefully for the better. Hopefully it's going to progress toward the better. So, initial step of the nursing process, because it is the initial step of the nursing process, we have to go in and assess our patient to know what we're going to do for that patient. If we don't assess the patient and we just read doctor's orders, we don't really know what's going on with our patient unless we go in and do the initial assessment. We want to gather information about our patient, and this information should encompass the whole person and help us identify areas that the patient deems problematic. The patient's strengths should also be identified so that we will know how well they're going to be able to help and how much they can help. So we need to know their strengths and their weaknesses. Strengths can be supportive in helping change their problems. Do they have the strength to change this problem in their life? And it can enhance the quality of their life. So as the nurse assesses the patient, we're using critical thinking to determine appropriate and relative data. So we're going to be able to do all these things in assessment. It's our initial step. We're going to collect all that information. We've got to make sure that it's holistic and very detailed. We're critically thinking about all the information that we pick up. We determine what kind of problems that this patient's having. Do they have the support and the strength to handle this? And of course, it's ongoing. As always, ongoing. Assessment is always ongoing. Subjective data versus objective data. Of course, subjective data, what did the patient or the significant other tell you? Objective data, what you or someone else observed or measured. So if someone else did vital signs and they wrote it in the chart, that's objective measure. If the patient says her pulse is running really fast, then that's subjective data. If we take her pulse and it's 110, then that's objective data because we observed it. So at this stage, like I said, we should be able to have this under our belt. So we have different sources of information that where we can obtain all of our information, and we have to look at all these when we are initially assessing our patient. The first and foremost, of course, is the patient. The patient knows more about themselves than anyone does, unless, of course, they're not mentally capable of giving you that information, or they're not able to speak, or whatever the reason. As long as they're able to communicate in a lucid manner, then that's where our most important information is going to come from. We should do a thorough history and physical, which you guys have learned to do this last couple of weeks. We should review their medical records because there may be something in their past that we need to know about. Diagnostic tests that's been ordered, we need to be sure we're looking at the results of those. The entire health team is essential to obtain a complete assessment. Whatever, if we need radiology, we need respiratory, whatever our problem with our patient is, and the things that have been ordered, laboratory. These people are all part of our health team. And significant others may be included if it's appropriate to ask them instead. A lot of times you go in there and significant other wants to tell you all the answers while the patient is sitting there not telling you anything. And you may have to ask that patient to leave the room so you can get your information from your patient. The data falls into two broad categories. It's either primary or secondary. The patient is the primary data source. All other data sources are secondary. So if the patient didn't tell you, if it didn't come from the patient, it's all the other data is secondary. So let's look at this critical thinking, clinical reasoning that Ms. Candler went over in the critical thinking exercise lecture portion. So we want to validate the information that we receive. So look for normal and abnormal findings. Whatever you find, you want to validate the data with the patient. If the patient says something to you, like I felt a lump in my breast, then you are going to look for that, and then you're going to say, well, this is what I've noticed. I feel a small lump that's not movable, and we talked about it in the breast assessment. So, that would be part of this is what I have noticed. Or they've complained about pain in their elbow. Perhaps you've noticed a reddened area at their elbow side. Validate what they say. they tell you they feel a certain way, and then you're going to say back to them, does this describe how you feel? Do I have this right? Did I understand you correctly that this is how you feel? If they didn't give you enough information, ask them to tell you more. And if it's something that they're wanting you to do something about, they're just telling you something and really upset about it, then, one of your questions may be to validate it, as in, what can I do to help? What do you think? If they're complaining about they're not getting really good care in the hospital, well, and you're the nurse, well, what can I do to help fix this problem? So be sure that you're validating, using your critical thinking. Immediate reporting of assessment information. You need to know when you should report information immediately. Nurse encounters a lot of these situations, and it should be reported immediately because you need to have appropriate action taken, and you can't get orders if you don't from your physician if you don't report them. So some of the things that you really need to make sure you're reporting is something out of the ordinary. Say your patient has not had sharp relenting pain. It's not been, and all of a sudden they start having sharp unrelenting pain. This is really bad in OB. You want to get your doctor on the phone immediately. If your vital signs have greatly deviated from normal, of course you want to check to make sure they've deviated from normal if you haven't already checked. Especially if they have a change in level of consciousness. If you've been caring for this patient for a couple of days and you come in the next day and there's been a change in the level of consciousness and no one has notified the doctor, this is a bad, bad situation. If you're ever in doubt whether or not you should report it, if it worries you enough that you think, should I report it, should I not, it really worries me, but I don't know if the doctor would think it's important, report it. All the doctor can do is slam down the phone or think you're a total idiot or come back later and say, thanks so much for telling me that. It made the difference, all the difference in the world in that patient's care. So I would rather be advocating for my patient instead of being afraid of the doctor. And it takes a long time to get that way when you're a new nurse, is not to be afraid of the doctors because they can be very formidable. So, be prepared to immediately follow those instructions that you're given. If you're calling the doctor about something that you think is important and needs, it's a change in your patient, be prepared that you're going to get doctor's orders to follow those doctor's orders and to get those things ordered and be prepared to do them because you want it done immediately. You don't want to say, well, I got this order for this sharp, unrelenting pain, but I'm going to lunch and I'll take care of it when I get back. That's not the answer. Okay, step 2, nursing diagnosis. This information was provided at the 9th Nursing Diagnosis Conference in 1990, and it's been applied in practice ever since then. So, the nursing diagnosis requires us to have clinical judgment. It can be for an individual. We can have a diagnosis for the entire family. We can even have a diagnosis that affects the community, because all three of these situations, the individual or the family unit or the community as a whole, can all have problems in the healthcare. So basically, our nursing diagnosis is going to be the response that we have to the actual or potential risk of health problems or life processes. It is our total basis for outcomes and interventions. So when we go to do our clinical reasoning tool, we have to have a basis for our outcomes, which are going to be our nursing goals, short-term and long-term, and then our interventions that we make for those short-term and long-term goals. It all has to go back to the nursing diagnosis. What is the problem? What do I want to happen? And how can I get it to happen? And the nurse is going to be held accountable for doing this nursing diagnosis correctly. So we do have a nursing diagnostic list. We have your nursing diagnosis book that has NANDA's approved list, but we are not going to go totally by these approved nursing diagnosis. We are going a little away from this in that we can select what we think is our actual problem, and if it's not in NANDA and it stands on its own, it's appropriate for your patient, then we can allow it to be a little bit away from NANDA. But you need to know that the diagnosis does come from the NANDA's list that I showed you in the nursing diagnostic book. Those lists are in the front page of the diagnostic book, and there are pages that have the green sides to them are all part of your NANDA diagnostic list. So there's actually 188 approved nursing diagnoses, but we all know there's more than 188 diagnoses or problems out there. You can obtain this list in that textbook that we showed you on the back covers or the front covers of the book, or you can access it at the NANDA website in the Evolve website for NANDA. So the Evolve website is where the diagnostic book is at. So critical thinking and nursing diagnosis. We have to have critical thinking to be able to develop a nursing diagnosis. Our nursing diagnosis is based on all the information we've gathered when we did our initial assessment. Information has to be analyzed. We have to see what's important, what's not important, how many complaints they have of this compared to that, which one's more important than that. Certain questions that we need to ask. So we want to say to ourselves, is the information in the assessment, did we get all the information we need? Would a nursing intervention support a change in this? Compare the data with the NANDA definitions. Do the signs and symptoms of the patients match the defining characteristics supplied in NANDA? So these are things we ask ourselves to be sure that our information is analyzed correctly. So for example, our problem is noncompliance. Our etiology is related to unresolved anger about diagnosis. So our problem is that when we did our assessment, we decided our patient was not complying with the treatment that the patient should be, that the doctor had ordered for the patient, because she's very angry about being diagnosed with this particular disease process. And what told us that is, first of all, she states, I hate to take the pills. I like my salt. Her objective data, she's gained 5 pounds. Her blood pressure is 180/100, and her LDH and her cholesterol are elevated. So this all tells us she's probably not taking her pills. She's probably eating a lot of salt. It's supported by her weight gain, her blood pressure, her pulse, and her LDH that we have as objective data. So all this points us up to the diagnosis of noncompliance. Absolutely. So what we're going to ask ourselves is, does that selected diagnosis that we picked out fit the NANDA definition? And this is with any of your nursing diagnosis. Does the selected diagnosis fit the NANDA definition? Physiological needs, inability to breathe, maintain an airway, problems interfering with homeostasis, respiratory, circulatory, hydration, elimination, problems interfering with the ability to be free of pain or nausea, skin care, rest, and mobility. Those are all related to the physiological needs. These are the Maslow's hierarchies of needs. Safety and security, things that fall under that one, diagnoses that fall under that one, anxiety, fear, environmental hazards, physical activity deficit, violence towards self or others, infection. And then love and belonging. So physiological needs is at the very bottom of the list. We should meet these first, right? Then our safety and security we meet second. Then next to that, we worry about love and belonging, sensory and perceptual loss, inability to maintain relationships, isolation, sexual dysfunction, loss of loved ones. These are all things that fall in that category. Then we get up to the higher category of self-esteem. Many people do not make it to self-esteem. They may have a lot of problems that interfere with self-esteem. They may have an inability to perform their ADLs, personal hygiene, things that are that interfere with their self-esteem. Then self-actualization is at the top, very tippy top of your Maslow's hierarchy. Many, many, many people do not ever get to actualization. Why is it so hard for me to say that word this morning? Many of them never recognize their actual selves. Okay? And this is achieving personal goals and positive personal assessments of life events. This would probably be one of the very last things that nursing is going to worry about. We're basically all about the physiological needs, the safety and security. Those are our two big things. We might step up into the love and belonging, especially if we go into the psychiatric portion of nursing, and possibly the self-esteem. But the self-actualization is usually not one that we are too awfully worried about. So when you're planning your diagnosis, be sure that you're following your Maslow's hierarchy. It's more important they breathe than they have a good job and they're proud of themselves. Step 3, planning. Planning, of course, can't be done until we decide what our problem is, what the nursing diagnosis is going to be. This is where we're going to write our goals. We have short-term goals and we have long-term goals. We've collected all of our data. We've made a diagnosis. So now we've got to plan what we're going to do. And our mutual outcomes are going to have to be determined, how we're going to accomplish them, and we're going to have to be able to measure those outcomes. Because if we can't measure them, then we don't know really if we've reached them. So we have to write measurable patient outcomes. These are going to be our short-term goals and our long-term goals. And then we have to have nursing interventions to accomplish the outcomes or the goals. These outcomes and interventions are designed to change the patient's nursing diagnosis or problem. So if my problem is about the patient being in pain, I don't want to set a goal of that they will increase their intake. I don't want to set a goal that they will be able to go to the bathroom by themselves. I want all my goals to be related to pain. I want all my outcomes to be related to pain. I want all the nursing interventions to be related to pain and into accomplishing the goals. So once I determine they have pain, I want a short-term goal that's going to help me resolve their immediate pain, and I want a long-term goal to help the patient realize over a certain period of time that she can decrease, how she can help decrease having pain. So these are things I'm going to be all about the diagnosis. So when you do this in your clinical reasoning tool and you're doing your goals and your interventions, be sure that you're not throwing stuff in there that's not related to the nursing diagnosis that you chose before you had to do those. So be sure we're writing measurable patient outcome goals. And in their nursing diagnostic book, there are some really good guidelines on how to write these goals. And be sure that you identify the interventions. We just talked about that it has to be part of and relate to the diagnosis. So remember that all goals that you write, the short-term goal and the long-term goal, has to have a subject, the patient, the community, the significant other, the mother, whatever. It has to have a subject, the person, the patient. Then you have to have a verb. What's that patient going to do? The patient will walk, the patient will drink, the patient will maintain. It's got to be an action word. What's the patient? The patient has to do an action. And then, of course, we have to have the action itself. What do we want the patient to do? It has to be measurable and it has to be realistic. Say you had a patient who had surgery, and this is a first day post-op. Your goal for that patient is that you want the patient to ambulate. So your goal would be the patient will ambulate 15 feet first day post-op within the first 12, or to make it even more specific, you would say the patient will ambulate, there's your subject, there's your verb, 15 feet, there's my measure, and it's realistic for my patient to ambulate 15 feet. It's probably that far to the bathroom. Will ambulate 15 feet within 12 hours post-surgery. So I've got a goal that has my subject, my patient. It's measurable, 15 feet. It's realistic. My patient should be able to walk 15 feet. And it does have an action, and it has a time frame. I'm going to do that within the first 12 hours post-op. Then I'm going to go back and evaluate this eventually, and I'm going to say the patient was able to walk 8 feet. Did I meet my goal? No. So the nurse that's coming on, when she sees your goal, that your patient did not meet the goal, then they're going to try to meet the goal, and it continues until you meet the goal, and then you can increase the goal or change the goal. And so these are things you have to keep in mind. Be sure that all your goals have those 5 things, or you'll get them counted off when you do your clinical reasoning tool. So some of the questions that you can ask in your planning, especially because this day and time we want our patients to be part of their care. Most of us are family-centered hospitals that we work at, and when you involve your patient, you have such a better outcome, because as the patient's involved in the planning, they're more likely to be compliant. So what does the patient hope to accomplish? Does your surgery patient hope to be able to get out of bed and begin to ambulate and get back into their activities of daily living? So what does this patient hope to accomplish? How should these patient outcomes be prioritized? So, patient wants to do 1, 2, 3 things. Which things should be done first? Which things should be done second? How should we prioritize those? How are we going to measure what they want to do? So if they hope to go home in 2 days, how are we going to, our outcomes are going to be, they're going to get up, they're going to ambulate, they're probably going to have to pass gas before they can go, and they have to have a pain tolerance level of probably less than 3. Those are 3 outcomes I would be looking at. And so I want to measure them. I have a less than 3 pain tolerance I want them to have, and I've got to have it within, she wants to go home in 2 or 3 days, it's got to be within 24 hours. It's got to be a short-term goal. So what nursing interventions can we do to help the patient with a satisfactory outcome? And most of our interventions should be, when we're planning, we should be planning that the patient will be doing the intervention. We're going to bring forth the intervention, but the patient will do that intervention. It's not something that we do for that patient, like, give them medications whenever they ask for them. That's really not a nursing intervention. That's nursing standard care. The nursing intervention would be that you taught your patient when to call for pain medication. You taught them the pain scale. You taught them that ways they might be able to decrease their discomfort. That might go on your long-term goal. So who's going to assist your patient? So you always have to do this. We call this delegation on your clinical reasoning. So for each intervention that you have, you need to write beside it, who will do this intervention. Now, you as the RN can't just leave it blank because you think, well, an RN's doing it, so I'm going to leave it blank because I'm going to do it. Because that's not what it means when it says to delegate. To delegate, it means what particular personnel can do this job. So when it's teaching, you should always have an RN there. When it's assisting to ambulate, you could have your CNA there. You could have give pain medication, you could have your LP in there. Reinforced teaching, you can have your LP in there. Assessment, you will always have the R in there. So be sure that, you know, if you're going to have breathing treatments done, you would delegate that to respiratory. You're not going to do that. Most hospitals do not do their own respiratory anymore. So be sure that you don't forget to put those on your clinical reasoning. So what is a NOC? Nursing Outcome Classification. This is a goal. This is an individual, family, or community state, behavior, or perception that's measured along a continuum in response to your nursing interventions. So outcomes may be selected from standardized nursing language. Examples are in the care plan you may have selected from the Ackley book. And a list again is also at the Evolve website. So be sure that they are along a continuum so we can measure them at any time. They're usually pretty neutral and they help us to set our goals. So these are the classifications. This is just telling you what nursing outcome classifications are not. So outcomes are stated as concepts rather than expected goals. Nursing goals was what we expect. So our short-term and long-term goals are what we use for expected goals, but nursing outcome classification is just measured along a continuum and are stated as concepts. So planning our outcomes. In order to plan those outcomes, we've got to set the goals. We've got to set patient-centered short-term goals and long-term goals. We've already talked about them. Always prioritize your goals by what is most important. If you need to do teaching to this patient, how much teaching will this patient be able to comprehend if they have just come from surgery, or if they're in a lot of pain, or if they're throwing up? You got to take care of some things before you can do other things. So be sure you're prioritizing those. So let's use that critical thinking that you learned from Miss Kimler's lecture. Does it come from the nursing diagnosis? Yes, hopefully our outcome comes. So these are questions you want to ask yourself when you're doing these interventions and setting up your short-term and long-term goal. Did it come from the nursing diagnosis? Do you have your subject? Is it measurable? Is it realistic? Do you have that verb performance criteria? Is there a time frame? And does it provide direction for care? Does the patient have to do the work? That's patient-centered. We want the patient to be very much involved in doing their care and meeting their goals. So we've talked a lot about time frames. These are what we consider time frames for short-term and long-term goals. Short-term goals should be obtained within 24 hours, and long-term goals are those that are set for after 24 hours. There are a lot of times that your goals are going to be long-term goals that you cannot possibly expect your patient to reach that goal in the length of time they're in the hospital. Those are your long-term goals. Now, the time frame is set for patients who are in acute care hospitals. If you have someone who's in the nursing home, in rehab, if you have them in psychiatric settings, your short-term goals are much longer than a 24-hour period. So when you go to your psych rotation, be sure you ask your psych instructor what she considers would be a short-term goal for the patient's problem that they have. But as far as when you're going to med-surg and OB, observation, any of those areas, your short-term goals are within 24 hours. Okay, now we're going to talk about nursing interventions. The nursing intervention classification is a comprehensive standardized language. It's going to describe the treatments that we perform in all of our settings, including our specialties. Again, you can get interventions from that list of standardized nursing language. There's a sample with each one of those nursing care plans that's in our Ackley book, and also on the Evolve website. So remember, I showed you in the book that you can look up the diagnosis, see what, you can look up the disease process, find diagnoses, look up the diagnoses, and under the diagnoses it will have short and long-term goals that may be applicable to your patient. And then it will have interventions that will relate back to those particular types of goals. So if you use your Ackley book a lot, this portion will not be hard for you. You won't be sitting there beating your brain about, well, what am I supposed to do about this? Well, what kind of intervention will fix this particular type of diagnosis? And don't get way off track. So the classifications usually include the physiological and the psychosocial interventions. Remember, when we're doing interventions, we should always include at least one teaching intervention. You will be counted off for not including a teaching intervention in your clinical reasoning portion of the exam. So, interventions can be activities that are done for and with the patient. This is your action verb. They accomplish outcomes. So if it's an intervention that's going to accomplish our outcome, this is the most wonderful intervention. It's going to remove, an intervention can remove or reduce related factors that contribute to that nursing diagnosis. Remember, I told you it always has to go back there. And it's always individualized. Can your patient actually do these interventions? Involve that patient in making that decision as whether or not you feel like they can do that intervention. Be specific and also make sure that the interventions are safe. It tells how long, how often, when you're going to do your intervention. So we really like to think about interventions being a roadmap guide to nursing care. The more clearly we write that intervention, the easier it's going to be for our patient to get to the end of the journey and arrive at the destination of successful patient outcomes. And this is what we want to see. We like to see our patients succeed. We like to see that we were smart enough to figure out those interventions that would help solve that problem. And that's part of our critical thinking. And the more critical thinking exercises we do, the more able we are to critically think. And the more we critically think, the better our nursing care is. So planning interventions, critical thinking. These are some of the questions you can ask yourself in order to come to your planning, what you need to plan for. What nursing interventions can I do to help my patient with satisfactory outcomes? Who's going to help my patient? Is it going to be the nurse? Is it going to be respiratory? Is it going to be dietary? Is it going to be the LPN? Is it going to be the RN? What kind of equipment do I need to do this intervention? Do I need a cath pump? Do I need an IV pump? Do I need special equipment for them to be able to eat? What kind of equipment do I need? Is the patient going to be able to afford this particular type of equipment? So is this reasonable? How long is it going to take this intervention? Is it going to be a short-term goal, long-term goal? Is it going to take this intervention? Which one of those goals do I need to put that intervention in? How often should I try to do this intervention? Should I do it once a day, twice a day, once a week? And then what evidence supports its effectiveness? So, have you evaluated and supported whether or not it's been effective or not? Did you do research and see if evidence-based practice said that it was an effective intervention to use for certain diagnoses? Step 4 is implementation. Implementation is of the interventions can be either dependent, interdependent, or independent. Dependent is if it's nurse initiated, interdependent is physician initiated, and then independent is collaborative, where the patient and the nurse works together, and the patient independently decides that this is, with the nurse's help, that this is what she wants to do with her evaluations. And that's really all there is to the implementation portion. Is that which one of us is going to implement it? The nurse, the physician, or the nurse and the patient? So step 5 is evaluation. Most important that you do your evaluations, because you can sit there and do your interventions all day long, and if you're not having any results and you don't change your interventions, then you're not doing your evaluations. If you're doing your evaluations, you would know to change your interventions. So, critical thinking, evaluation. Be sure you check the patient outcomes. Were the outcomes satisfactory? Did the patient reach the goal? Is additional assessment needed? Maybe something else is going on. Maybe this intervention is just not doing what we need it to do. Were the outcomes realistic? Were we able to, was the patient actually able to do this particular type of intervention, and was it realistic of us to think they could, so that this, was our patient actually able to walk that 15 feet? What if our patient had hip surgery? It would not be very realistic for us to think they're going to walk 15 feet the first day post-op. So be sure that we're realistic with our outcomes when we evaluate if it's not working. Did we select the right nursing diagnosis? Maybe we should rethink the diagnosis and rethink the nursing plan. So, as a final, remember, document and report. If you didn't chart it, you didn't do it. You can say you did it all day long. You can have done it all day long. The patient can say you did it all day long. But if you didn't document it, it wasn't done. So be sure that you're doing good documentation. Anytime you do anything for the patient, you should be making an entry note. I know that at this point in time, all the electronic MARs are just click here, click there, click here, click there. But unless you're documenting in the nurse's notes, it doesn't really reflect that you're having patient interaction, and you really want to have patient interaction. And you especially want to document that you had patient interaction. So don't be just a clicker, be a doer. Be a documenter. Get in there and document. Alrighty, that's the end of this one.